Good evening, everyone. Welcome to the Mahamana case discussion series. So, the regular participants might be knowing that it's a two-part series. The first part is an invited talk, and the second one is a case discussion. So, without much ado, we'll proceed. And for the talk today, we have Dr. Neelesh Tiwari. Dr. Neelesh is a consultant in head neck surgical oncology at Jawaharlal Nehru Cancer Hospital and Research Center, Bhopal, and he'll be talking about common sinonasal malignancies and their management. So over to you, Dr. Neelesh.
Thank you, Dr. Komal. I'll just share my screen. Yeah, good evening, everyone. I hope everything is visible and audible.
Yes, it is.
Yeah. Okay, so I'll be speaking about different set of tumors today. The sinonasal malignancy pose a kind of different set of challenges in management for an oncologist. The anatomy of the region is a bit complex. It has many vital structures. One sec. I'm sorry. One sec. Sorry, I lost my screen actually.
It's okay. Take your time.
Yeah, is the slideshow visible?
Yes, it's visible. Please go ahead.
Okay. So the anatomy here is a bit complex. There are a lot of vital structures like neural structures, many nerves entering into the skull base foramina, the orbital contents. The spectrum of pathology which we deal in paranasal sinuses is vast. WHO classification gives more than 40 list of pathologies, and each histology has a different set of management. So histology-based treatment strategy is of prime importance. The surgical approaches do follow the same oncological principles, but the concept of margin is a bit different from our regular two-dimensional distance in case of other head and neck areas. And an expert multidisciplinary team is a must for making a decision and uh, going ahead with the treatment plan. This is just a snapshot from WHO list, which basically classifies all the tumors based on their cell of origin. We have epithelial tumors, mesenchymal origin like bone and soft tissue, neuroendocrine tumors, neuroectodermal, germ cell tumors, and hematolymphoid. Some common pathologies which we deal in our practice are squamous cell CA, adeno-CA, adenoid cystic, sinonasal undifferentiated carcinoma, neuroendocrine carcinoma, esthesio. These are some bit more common pathologies that we deal. The message is that for different histologies, we need to follow histology-specific treatment strategies. So, as we know that these tumors are not very common. They are less than 5% of all head and neck cancers. Incidence is low, though this is Western data. The males have higher preponderance, and with age, the incidence increases. And usually from fourth and fifth decade, we see more patients, and the prognosis also changes with the age. The survival roughly for overall cases is roughly 50%. There are certain risk factors described. Tobacco smoke is known to play role in squamous cell CA, and other industrial exposures such as wood dust in furniture industry, leather dust, nickel have been known to cause certain pathologies like squamous cell carcinomas, adenocarcinomas. Certain pathologies like esthesio, neuroblastoma, melanoma, or sarcomas do not have well-known etiological agents. Out of all the sinuses, maxillary sinus is the most common affected site, followed by the nasal cavity and ethmoid. And squamous cell carcinoma is the most common etiology, most common pathology affecting these tumors, followed by adenocarcinoma, esthesioneuroblastoma, and adenoid cystic CA. The regional metastases to the neck nodes are known to vary from pathology to pathology. And it may vary from as low as 3% to 30%. So again, the address of neck nodes depends on the pathology. Distant metastasis occurs in very few high-grade pathologies. So how do we evaluate and come to a treatment decision based on our clinical features, followed by radiology and endoscopy and biopsy? We need to have a MDT discussion in which all the parameters with pertaining to MRI features and especially histopathological features need to be discussed, and then we come upon the treatment plan. So the symptomatology mainly has non-specific symptoms like nasal obstruction or a loss of smell, epistaxis. These are the initial symptoms which all the patients get, and they are often misdiagnosed earlier by the first clinician, which is usually ENT surgeon, and there is delay in seeking care by patient as well, which result in most of the patients presenting at advanced stage. And very often, these tumors are mistaken for polyposis and other benign conditions and undergo FES or other non-oncology directed surgery and later on get surprised by the pathology and then referred for the further management. So the symptoms mainly we see based on the structures involved. If the orbital structures are involved, patient will have proptosis, diplopia, or epiphora because of nasolacrimal duct obstruction. In case of breach of the anterior wall of maxillary sinus or nasofrontal framework, there will be facial swelling. And if the extension is towards the alveolus, there will be loosening of tooth or even ulceration in the palate or upper alveolus. Then there can be neurological symptoms in advanced cases when there is definite infiltration of brain parenchyma, such as headache or seizures. And we often see cranial nerve deficits, especially if there is involvement of orbital apex, there will be diminution of vision. And further posteriorly, if there is involvement, if there is extension into the cavernous sinus, we'll have paralysis of the extraocular muscles. So the cranial nerve examination forms an important part in our clinical examination. So imaging is a very important tool and should preferably precede biopsy because the MRI, because of the imaging, our imaging methods will help us in characterizing the lesion, and there are certain pathologies which are known to cause a lot of hemorrhage during biopsy. So one can be careful. CT and MRI are common modalities, and they most often they complement to each other. Both these modalities help in staging the tumor, which essentially focus on four issues such as orbital infiltration, involvement of anterior cranial fossa, posterior. Sorry. Sorry, any issue?
No, please proceed. There was some.
Okay. So posteriorly, it may extend to pterygopalatine fossa or infratemporal fossa, and there may be perineural spread along the trigeminal branches up to this skull base and cavernous sinus. . So CT mainly helps in deciding about the bony erosion or whether it is a bony remodeling and caused by the expansile nature of the tumor. MRI with contrast and fat suppression sequence helps in identifying the tumor architecture, the soft tissue spread along the nerves, and the orbital and intracranial extension. We'll see with few examples. And distant workup is necessary in many pathologies, especially in high-grade tumors. A PET CT is preferable, but uh, there may be certain practical challenges. So even CT thorax will cover most of the distant mets at presentation. Usually the distant metastasis as presentation is less than 5% of cases. So this is an example of a frontoethmoidal tumor. On CT, on CT, there will be a homogeneous opacity, and it will not give us much information about the extent of the tumor or involvement or attachment of the tumor. So this is a MRI with a T2 sequence, which shows a very well encapsulated mass and probably attached to the septum. Say, same patient, a sagittal scan, which it will show the exact extent superiorly and whether dura is involved or not. In this case, it is only abutting the dura as there is no definite enhancement of the dura. Another example, how MRI adds more information to your CT findings. This is a ethmoidal mass, which is contained in the nasoethmoid region, and the opacification on CT may overestimate the size or extent. On MRI, especially in T2 sequence, T2 the water is seen white, so the secretions will be seen differently from the mass. So the sphenoid has only secretion in it, and the mass is limited anterior to sphenoid. To assess the orbital extent, the MRI is a very useful tool, especially the T2 and T1 sequences. In T2 sequence, the lamina papyracea, medial wall, and periosteum will be seen as a very thin line, thin black line. And any irregularity in or breach in this line will indicate towards a possible involvement of the orbital fat. Sometimes the lamina papyracea is demineralized and only a small periosteum, very thin layer of periostea remains. Similarly, dural involvement is best seen in sagittal sections in post-contrast T1 sequences. Some definite signs of dural involvement are the nodularity of the dura, not just enhancement, as a thin rim enhancement is seen in any tumor which is pressing on to the dura. The involvement, the nodularity, the irregularity in this line in the sagittal section confirms the presence of dural infiltration. We'll take another example. In this case, this is a nasoethmoidal mass pressing onto the orbital region. Here, there is no there is no bony lamina papyracea seen on the CT. So on T1 images, the fat acts as a good contrast agent. You can see that the indentation on the extracorneal fat is very smooth, and the chance of infiltration is less likely, as seen in T2. Now, this specific part of the tumor has hyperintensity, which indicates it's a cystic component of the tumor, and which is only pressing on the on the orbital fat. And even though extraocular muscles, the medial rectus is just pushed aside. On contrast, there is no extra enhancement of the the medial rectus, which shows that it is not directly infiltrated by the tumor. And on coronal sections, we'll see the superior extent into the cranial cavity and involvement of the dura. Perineural spread, which is very often seen in adenoid cystic CA, which may or may not be contiguous with the lesion. So in even a maxillary sinus controlled, a very controlled location of maxillary sinus also, there may be some extension along the trigeminal nerve, along the foramen ovale in the cavernous sinus. Now, biopsy, some practical tips. Preferably, we should do endoscopic biopsy and most often it is possible under surface anesthesia. Sometimes in uncooperative patients or pediatric age group, GA is preferred. One should always avoid violating any planes. If the swelling is seen directly on the malar region or in the periorbital region, one should not directly jump on taking incision biopsy from that area. Similarly, for maxillary sinus lesion, we should avoid Caldwell Luck procedure as it violates a very healthy GB sulcus area and other soft tissue if the disease has not breached the anterior wall. And in any case, one should be ready for management of uncontrolled epistaxis, as we'll see on MRI before the biopsy. Certain very vascular lesion will show a lot of sinusites on T2 images, which will indicate that there are a lot of vascular channels in the mass. In such cases, one should be very prepared for control of epistaxis. Coming to staging, there are a lot of staging systems, and because of the different pathologies, most common we follow the TNM stage, and same for epithelial C or soft tissue sarcoma. For esthesio, the CADIS staging or Dulgura are more practical staging systems which help in prognosticate and decide the management plan. I'll skip because this is a common. The basic concept for from T1 to T4 is the extension from intrasinus disease to the adjacent areas and involvement of the adjacent structures such as orbit or intracranial components. Now, we'll look in some of the common histologies and about their management. Squamous cell carcinoma is the most common sinonasal malignancy, as we saw, and most commonly affects the maxillary sinus. Inverted papilloma, which is a benign condition, can be associated with squamous cell CA in 10% of the cases. There is a propensity for neural invasion, and which is a poor prognostic factor, and also nodal metastasis seen, especially when there is involvement of frontonasal framework or breach of anterior maxillary wall, and is associated with poor prognosis. Ideal management is upfront surgery. Whether the approach of surgery depends on the site of the lesion. Maxillary sinus lesions mostly go for one of the type of maxillectomies depending on the extent, and neck dissection in many of the cases. If it is a limited nasoethmoid squamous cell CA, neck dissection can be avoided, but neck should be irradiated with the adjuvant RT. 5-year survival is good up to the rates of 70%. Now, induction chemotherapy, there has been some studies in squamous cell CA also, though there is no level 3 evidence, but in some cases, they have shown good results in preserving the orbit, especially in locally advanced cases where the involvement of orbit is not clear on the imaging. And some studies have reported on ease of resection and achieving negative margins, though the real impact on overall survival is still debatable. Adenocarcinoma are of usually two types, intestinal and non-intestinal. And in non-intestinal type, there can be high grade or low grade. And in intestinal type of adenocarcinoma, the P53 mutation is the most common genetic abnormality, which also helps in deciding the prognosis and management. Again, mainstay is surgery. In low-grade cases, surgery itself may suffice. In high-grade cases and higher stage cases, we need to follow it up with radiation. It has a very low level of regional metastasis, so neck dissection is not advised, though the upper levels of neck and retropharyngeal area should be included in the radiation field. NSCT has role only in selected cases in higher stages of intestinal type of adenocarcinoma with a functioning P53 gene. Such patients have shown to respond better to the overall treatment. NSCT is followed up with surgery and radiation. 5-year overall survival is also up to 70%. Now, esthesioneuroblastoma is peculiar in its bimodal peak of presentation in second, third, and sixth decades of life. Kaddish staging is based on the extent. It is limited to nasal cavity and ethmoids. It's Kaddish A or B. There is dural involvement. It's Kaddish C. And if there are regional and distant mets, Kaddish D. There are four grades of HAMS based on the certain histopathological findings. And in high grade tumors, ISCs play a very important role in differentiating it from other similar tumors. And they are typically seen positive for S100, chromogranin, and synaptophysin. The lymph nodal metastasis rate is ranged from 5 to 12% in different studies. In N plus cases, obviously, we should go ahead with neck dissection, but in N0 cases, elective neck irradiation, bilateral and retropharyngeal is recommended. Grade 1 and 2 cases, usually surgery followed by radiation. And in higher grade cases, NACT has shown uh, better outcome in achieving the surgical resection and overall survival as well. In lower stage and lower grade cases, the whether to remove the olfactory bulb without its involvement is a continued debate. Some people there is different schools of thought. Some people advocate that even because the site of origin is neuroepithelium, so even if olfactory bulb is not involved, one should remove the complete neuroepithelium from olfactory fossa. This is a typical MRI of an esthesioneuroblastoma. It often has uh, cystic components extending to the cranial cavity. It has a very long natural history and sometimes it's indolent as well, especially low grade. The recurrences are seen quite late in life and they present either as local recurrence or regional nodes. 5-year survival rate are as high as 86%, and even 10-year survival seen in 50% cases. And now coming to sinonasal neuroendocrine CA, it's a very high grade pathology and difficult to differentiate with high grade of esthesioneuroblastoma. They are usually seen as small round cell, similar to small round cell tumors. Uh, the specific neuroendocrine markers such as CD56 and NCAM are used along with synaptophysin and chromogranin. But there can be many cases where SNEC may not be differentiated with high-grade ENB, though the management line for both the high-grade pathologies are same. So overall management remains same. And if these respond to chemotherapy, it is considered as a good prognostic factor, and 5-year overall survival is 70% in many studies. So a basic algorithm that in SNEC, if after chemotherapy the resist response is more than 50%, and or if it is less than 50% and tumor resection is not possible, then directly chemo and radiotherapy may be attempted. And if the response is less than 50% and with tumor resection feasible, then surgical resection should be the treatment of choice, followed by radiation. This is not a definite guideline. This is one according to one paper that, and especially in the US, uh, they are tilted more towards the CTRT when there is complete response or near complete response. Now, sinonasal undifferentiated carcinoma is a kind of diagnosis of exclusion histopathologically. There's no clear lineage pattern, and they often are very aggressive tumors. Uh, in recent years, many pathologies have been carved out from this particular entity as there is a evolution of immunohistochemistry. The SMART B1 deficient tumors is one such pathology. All these have very poor prognosis, and 5-year survival is dismal. Distant mets can occur, so getting PET CT at upfront evaluation is important. Uh, One algorithm is that again induction chemotherapy is given with cisplatin and docetaxel, and if the response is favorable, surgery can be reserved for salvage settings, and the responses have been seen to combine chemoradiation. In case it does not respond to chemotherapy, surgery with adjuvant radiation should be given. Now, adenoid cystic CA are from the salivary gland origin in the nasal cavity area. Maxillary sinus is the most commonly affected site, and it's very notorious for perineural spread and bone erosion. The lung mets, they are common at presentation and at further natural history, natural course of the disease. Nodal metastasis is rare. So the surgery and radiation are the uh, main paths for the treatment. Chemotherapy does not have any role in this as of now. And even with presentation of lung mets, if the performance scale of the patient is good, we can go ahead with surgery as the doubling time of this particular pathology is low, and patient do survive with good quality of life even with the presence of distant mets. And local recurrence do happen along the perineural area, and most often the salvage surgery is not feasible, so palliative radiation should be considered. Mucosal melanoma are itself quite rare, but out of the head and neck mucosal melanomas, paranasal sinuses are the most common site. They are very often they are pigmented lesion, but it's not exclusive, and they have very high incidence of distant mid. Complete surgical resection with clear margins is the gold standard. And median survival is seen to be quite low in these patients. They typically fail in distant sites and quite unusual sites, not lung and liver, though liver is the most common distant site of failure. Now, some points about surgical management. The craniofacial resection, which was introduced in 60s and 70s, has evolved from complete open craniofacial towards complete transnasal endoscopic craniectomies. The principle of resection is considered as sequential resection. Though we do not remove tumors a block, but it's not a piecemeal resection. The margins are formed by the structures which are present in the next compartment of the tumor. Suppose the tumor is limited to the septum and nasal cavity, the medial turbinate and ethmoids will form our lateral margins. And similarly, for tumors attached to the cribriform mucosa, the olfactory fibrils and olfactory dura will form the superior margin. This recent study published last year is a result of multicentric collaboration, and which shows that our endoscopic surgeries has a good overall survival and good quality of life, which was the debate in earlier years whether the sequential resection or piecemeal resection is inferior to open resections. How do we decide about which approach to choose? Some indications for open approaches include the involvement of frontonasal framework or the lacrimal structure, or directly involvement of palate and upper alveolus. Similarly, if the dura is involved lateral to an imaginary line passing through the mid-pupillary region, we prefer an open approach, as the complete negative margin may not be feasible endoscopically. Involvement of orbital muscles or orbital fat needs orbital exentration. And the criteria for unresectability has decreased over the years as more aggressive surgeries are taking place. Certain criteria such as very extensive dural and brain parenchyma involvement of orbital apex and further posteriorly into the cavernous sinus or Meckel's cave, involvement of carotid artery or cellular and supracellular areas are features of unresectable tumors. Usually these tumors are managed with CTRT. That's about the basics of the management. I have not delved into the steps of the surgery. I think time is also over.
A constraint. Yes. Thank you, Dr. Neelesh. Thanks for the good overview of the sinonasal malignancies that we commonly encounter. And yes, definitely, you would have gone on and on, but because there were time constraints, you have restricted yourself.
slides
Yes,
after
I
this
know.
also. If the time is
So,
there, I can show some steps. I don't think, right? The case presentation will be better. I think case discussion.
yeah.
Yeah.
So
Okay. Thank you.
thank you so much, and I would request you to stay back for the case presentation also, if possible.
Yeah. Yeah.
And so, if there are any questions from the audience, please drop them in the chat box. And we'll proceed to our next session, which is the case presentation. So the case presentation is on sinonasal mass, and the presenter is Dr. Abhisek Menon, who is a resident at Tata Memorial Hospital, Mumbai. And the moderators for the session will be Dr. Shivakumar Thiagrajan. Sir is Professor, Head Neck Surgical Oncology at Tata Memorial Hospital, Mumbai. Welcome, sir.
Thank you, Kamari. Good evening.
Good evening, sir. Then we have Dr. Kaberi Kakati. Madam is Associate Professor, Head Neck Surgical Oncology at Dr. B. Barua Cancer Institute, Guwahati. Welcome, ma'am.
Hi, thank you. Thank you so much.
And next we have Dr. Ankit Mahuvakar. Sir is Consultant, Head Neck Surgical Oncology at HCG Cancer Center, Mumbai. Welcome, sir.
Thanks, Komal. Thanks. Hi.
Hi. And Dr. Abhishek, best of luck. Over to you.
Thank you. Good evening, everyone. Is my screen visible?
Yes.
Yes, it's
Okay. I'll start then. So my patient is a 40-year-old gentleman, resident of Kolkata. He is a shopkeeper by occupation. He has no known comorbidities. He presented to our OPD with the chief complaints of bleeding from the right nostril on and off since the past 6 months. The patient was apparently asymptomatic 6 months ago when he noticed bleeding from his right nostril, 1 or 2 episodes per day, which was spontaneous in onset and stops on pressure. It was mild in amount, about 3 to 4 drops in during each episode. There was no history of any nasal obstruction or decreased perception of smell, no history of any cheek swelling, no history of loss of sensation of the cheek, no history of loosening of teeth, no history of any ulcer in the oral cavity or any history of watery eye discharge. There was no history of any eye symptoms such as protrusion of eyes, double vision or blurring of vision, no history of reduced mouth opening, no history of decreased hearing or ear discharge, and no history of any swelling in the neck. And there was no history of any headache, vomiting, or seizures. Coming to the personal history, he denies any addictions, has no other comorbidities, and has normal sleep and appetite. May I proceed to the examination?
So, is that all your presentation is about, Abhishek?
So he did not have any other positive symptoms, sir. These are I ruled out the other negative symptoms from my history.
Did he receive? Did you mention about the whether he has received any treatment for this?
No, sir, I have not meant. I have taken. He has not received any other. No history of
No,
any.
you're presenting a case, right?
Yes, sir. No
Yeah,
other.
so you
No
cannot
history
give
of
it to
previous
yourself.
surgery.
Sorry?
No history of any previous surgeries or any procedures done in the past, sir.
Right. Okay. So the personal history just is about habits, is it?
The habits is one factor for the etiology, seeing as tobacco or snuff tobacco or alcohol is one of the etiologies of sinonasal tumors.
Right.
Abhishek, did
any
you
other
mention about the? Okay, sir.
Sorry, go ahead, Kaberi. Go ahead.
Abhishek, did you mention anything about the occupation? Because as you had seen in
Yes, ma'am.
Neelesh's,
He's a textile
shop.
cloth
Yeah.
shopkeeper by occupation.
Yeah. Okay. Textile. Okay.
Yes, ma'am.
So, and in
Any
your negative history, yes, sir. Sorry.
No, sorry. Go ahead.
Thanks, sir. So, in your negative history, what is the correlation with the ear discharge and the nasal symptoms?
Ma'am, for any lesions involving the nasopharynx, if there is obstruction of the eustachian tube because of the lesion, that might produce serous otitis media, which might cause ear symptoms in the long run. So just to rule out that, ma'am.
Does that have any a name to it? That association of nasopharyngeal carcinoma, serous otitis media, and otalgia. What is it known as?
Not able to recollect, sir.
It's an ENT.
That's an MSc ENT
Yes,
question.
yes.
Right.
Yes.
It's known as the Trotter's triad.
Yes, sir. Trotters. Yes, sir.
You cannot falter in this.
Yes, sir.
So, what is the any association of occupation with the type of particular type of histopathology of sinonasal malignancies?
Yes, so primarily the most amount of evidence that we have is for woodworkers, and most commonly seen in and it's most commonly implicated in adenocarcinoma, and wood and leather workers especially,
Okay.
and they say that hardwood is generally associated with hardwood workers associated with adenocarcinoma, whereas wood workers is more associated with squamous cell carcinoma.
Which part of the
Abhisek,
world is it seen more commonly?
I'm not sure. I think Eastern Europe. I'm not sure of this, but I think Eastern Europe is more common.
Italian countries, yeah, Italian region, that is. Okay, yeah.
Yes.
Ankit, you had something to ask? Please go ahead.
Yeah, you said that there is an association between the occupation and the nasopharyngeal nasal malignancies. Any association with the temporal association? And what amount of work does the patient or the person needs to have an exposure to? The amount of time. Is there any idea? Do you have any idea about the amount of time the patient needs to be working with hardwood, softwood to finally say that that is the reason for him having this disease?
So it is more commonly associated with a long-term exposure to these carcinogens. I'm not sure about the exact time, sir.
Okay. Okay. So basically, association of close to 30 years. Patients,
Okay.
they generally develop it once they have actually left their jobs. So that is most commonly the presentation of occupational hazards, because in other countries, the occupational hazards are actually being made to pay, the treatment is being paid by the person who is employing the people. So that time frame becomes important.
Okay, sir.
Good. Go ahead.
So coming to the examination, the patient.
Hold on. Anyone
Yes,
else wants to ask any question or? So at the end of the history, Abhisek, do we always straight away jump into the examination? I'm sure this is not the first case you're presenting.
Yes, sir. Sir, I would like to summarize my findings. It's of
Yes.
Sorry, sir.
Yes.
Yes,
So
sir.
that
Yes,
needs
so-
to be done without
Yes, sir.
saying.
I would like to summarize my findings here. My patient is a 40-year-old gentleman from Kolkata who was a shopkeeper by occupation with no known comorbidities, with the chief complaints of right-sided nasal bleeding since the past 6 months. My differential diagnosis.
No, you don't give differential diagnosis here. You just have to
Okay,
summarize your
yes,
findings here. If the examiner asks you for a differential diagnosis, you can give.
Okay,
At the end of your history, you have to say some relevant, points in the history
Yes, sir.
that you would want to say, if at all. That is it. And if the examiner asks you, you can say what you're thinking of differentials at this point in time.
Yes, sir.
Okay, go ahead.
So on examination, the patient is conscious, well oriented. The pulse is 74 per minute, and BP is 120 by 70 millimeters of mercury, and the respiratory rate is 14 per minute. There is no paloicterus diagnosis, clubbing, or generalized lymphadenopathy or pedal edema. Systemic examination is normal. Coming to the local examination, there is no obvious swelling over the cheek. The intraoral examination, there is normal mouth opening. No obvious lesions seen in the hard palate, upper gingival sulcus, or the buccal mucosa. There is no proptosis or chemosis of the eye. On palpation, I have confirmed my inspectory findings. No tenderness seen of the anterior maxillary wall. On anterior rhinoscopy, there is inferior turbinate hypertrophy, and there is no obvious lesion detected. On eye examination, the finger counting at 6 meters is normal. The extraocular movements are normal. Sensation over the face is normal, and the rest of the cranial nerve examination is normal. On performing a diagnostic nasal endoscopy.
What are the cranial nerves you examined, Abhisek? Can you just say one by one and how you did that?
So primarily it is the optic nerve that I would like to examine, sir. In the
Which is the first cranial nerve?
olfactory, sir.
So shouldn't you start your examination with your olfactory nerve?
Yes, sir.
That's the basic teaching. How do you olfaction? What all did you do to assess olfaction? What all did you do?
Yes, sir.
How did you examine for the olfactory nerve?
So the olfactory nerve, generally we keep scented substances, and we ask the patient whether the patient can perceive the smell. It is that's how it is done in the.
So you take what do you call Axe and various whatever different companies, and you just keep it in front of him and ask him to smell.
Scent such as peppermint is you generally use, sir.
How do you present it to the patient?
Do you blind the
what is the
patient?
second kind? Sorry?
Yes.
You blind the patient.
Yes, the patient is blinded, and the different vials are presented to him, and he is asked to recognize the smells.
Right. And then what do you do?
And
okay, now that
yes.
Okay, you've done olfaction. Next, what do you do?
Next is the second cranial nerve, is the optic nerve, where visual acuity is confirmed. In the clinic, I would fairly gross examination by performing the finger counting test at 6 meters is done. Next is the third, which is
is there any chart that you would want to use if it is at your disposal?
For color, yes, for color blindness, the Ishihara chart is used, but generally it is
more than color. You're not worried about color blindness here. Any chart? I give you the hint.
Yes, the field of vision.
Okay, you're looking at the field of vision. Yes. Okay. Anything else for the visual acuity?
Yes, so that's the perimetry for the field of vision, and chart.
If you have the Snellen's chart with you, would you not use it?
Yes, sir.
That's what I'm saying. Snellen's chart.
Okay. Yes. Sir.
Okay. Fine. So what else do you do now? Okay, and what other examination would you do for inspecting the eye?
So the
if you have, of course, you wouldn't have it, but go ahead with your next cranial nerves. Yes,
the oculomotor nerve is examined by basically the cranial nerves 3, 4, and 6, sir. The extraocular movements are examined by I would like to ask the patient to follow my finger in the direction, follow his gaze in the direction of my finger by keeping the patient at a distance of around 30 centimeters. And that is how the cranial nerves 3, 4, and 6 are examined.
Okay. And then
next is the trigeminal of the cranial nerve 6, which is where the patient.
Trigeminal is 6.
5, sir.
Okay.
Where the sensation over the face is checked by blinding the patient and using a cotton wisp, and to assess whether the patient can perceive the cotton wisp over his face, whether the sensation is perceived.
So can you just tell what all examinations you'll do for the? I'm sorry, the others can ask the questions. I'm sorry. I just wanted to ask the examinations of different cranial nerves just to sensitize the fact to everyone that you cannot just escape in a skull-based neoplasm by saying I examined all the cranial nerves and it's okay.
Correct, sir. Truly agree.
Agreed.
Yeah.
100% agree.
So that is why I just wanted to really make Abhisek is a master at it. He will just mention it as a passing comment without realizing how important it is.
No, sir.
So when you are having a sinonasal malignancy as your case, you better know what your cranial nerve examinations are.
Yes, sir.
You better know in detail as to how you'll examination all the cranial nerves 1 to 12.
Yes, sir.
You cannot just say this. Most of it, what you've said is just, just touching superficially around the various cranial nerves that you're examining, but you need to read it up.
Yes, sir.
This is not enough. It may just avoid some penalty that would be imposed if you really didn't even say all of these, but it may just about save you, not do anything better than that. So please realize that when you have a skull base lesion, as a case.
Yes, sir.
Yeah. The others can please go ahead with any questions if they have.
Sir, Nilesh here. Just want to highlight one thing, sir. Hello?
Yeah, Nilesh, please go ahead.
Yeah,
Continue.
for the during case presentation, that when patient has decreased smell, it may not always be because of involvement of the olfactory fossa. As the wall completely mass is occluding the nasal cavity, the airflow will be low. So in that case also, even decreased sense of smell will not be definite indicator of olfactory involvement.
Correct. That's a great point, Nilesh. Yeah.
May I continue?
Anyone has any questions, please go ahead. Kaberi or Ankit?
No, sir, I don't have. You can go ahead with the.
Yeah, go ahead.
Yes, sir.
Abhisek, go ahead with your.
Yes, sir. On performing a diagnostic nasal endoscopy, there was a proliferative mass seen involving the right nasal cavity arising medial to the middle turbinate, involving the ethmoid air cells and posteriorly extending to the nasopharynx. The floor of the nasal cavity is normal. Rest, there was no other positive findings. On palpation of the neck, there was bilateral.
Just a minute,
Yes,
Abhisek. Okay,
yes,
so
sir.
what are your diagnostic nasal endoscopy findings? Proliferative mass seen involving the right nasal cavity arising from the medial to the middle turbinate involving the ethmoid air cells, posteriorly extending to nasopharynx. Floor of the nasal cavity is normal. So you're not commented on the nasopharynx as such. It's just you're saying, could you visualize the entire nasopharynx or
Yes,
not?
sir, I was able to pass my endoscope completely to posterior till the nasopharynx. The nasopharynx was normal.
So who will say that?
Abhisek,
Yes, sir.
Abhisek, whenever we do a diagnostic nasal endoscopy, you'll have to, the aim of doing a diagnostic nasal endoscopy is not just to identify the disease, but also to map the disease. That means
Yes,
anteriorly, the mass is coming till what level, posteriorly till what level, the floor is free, the septum is free, the superiorly, the mass extension is to what level. You said that it is medial to the middle turbinate. Whenever we do a diagnostic endoscopy, we can actually lateralize the middle turbinate and see how much the disease is going posteriorly. Plus,
yes,
it is not just one nasal cavity. God has given us two. We need to also see the
yes,
opposite nasal
opposite.
cavity.
Yes, sir.
Getting it?
Yeah.
Yes, sir.
By default, your opposite nasal cavity will be covered up in your imaging. But when you're doing a diagnostic nasal endoscopy and you are saying it in an exam, please make it a point that you
Yes.
map the disease perfectly, characterize the disease. Like, for example, it is bright red, angry red, it touches on bleed. See, these are certain things
Okay.
which
Yes,
will
sir.
give you an input about what it could be.
Okay.
Got it?
Yes, sir.
Or it
Understood.
could be very firm mass which you mobilize and it doesn't bleed. Sometimes it might be a pedunculated mass. Sometimes it is sessile. So you need to identify, tell all these points because these points help not just in decision making of your treatment, but also gives a rough idea about what it could be.
Yes, sir.
Got it?
Yes, understood.
So Abhisek, I think
Yes,
those
sir.
are great points mentioned by Ankit, and you need to mention that. You're just
Yes,
making
sir.
all these comments as a passing comment, rather than really, it's not giving a feeling of as though you've taken this case seriously. You're just mentioning it for the sake of it. I mean, what if this case really comes to you in the exam? You need to present it that way. If this is the
Yes,
way
sir.
it's
Yes, sir.
going to be presented in the exam, you'll be in trouble, I must say. I think we have said this enough number of times. So go ahead with your presentation.
Yes, sir. May I proceed?
Abhisek,
Yes.
Abhisek, just back to the previous slide. What about the neck nodes? You have not mentioned anything
Yes, ma'am.
about the size and all this stuff.
Ma'am, they were approximately 1 centimeter. Bilaterally, the 1B nodes and the left level 5 nodes of palpable, it was soft and mobile. They were approximately 1 centimeter in size. There was no fixity to the skin or the underlying mandible or the muscles.
So all this has to be mentioned. And
Yes,
when
ma'am.
you were saying it's in level 5, Usually we do not get till level 5.
Yes, ma'am.
So
Yes, ma'am.
in level 5, actually, you should also check for, what should you also check for in level 5? What is the important structure there?
Uh,
You should also check for the hand movement, the plexus, brachial plexus, and everything is also there. So
Okay.
mobility and all those nerve, whatever might be present there, you should also examine that.
Okay.
And what does neck node in a nasal mass indicate? What is the incidence of neck nodes in a nasal?
Ma'am, it is not very common. It is around 10 to 12%. It generally indicates advanced stage disease in the
Not only
sinus.
advanced and aggressive histology. So you might be dealing with an aggressive histology
Yes,
as well,
ma'am.
right? So all this from your history and examination, you can actually get an idea about the
Okay.
mass you are handling before you get a biopsy.
Yes,
Right?
ma'am.
Okay, go ahead.
And if you have a node in level 5, where could the possible site of the primary be in the skull base?
So in a skull base or in general in the head and neck, sir?
Yeah, having sinonasal malignancy. So I presume my question is restricted to that. So if you have level 5 node, where
Yes, sir.
could the possible extension of the primary be or site be?
So nasopharyngeal malignancies.
Of course, yes. That is
Yes.
what I'm trying to elicit.
Yes.
That so
Yes.
it could probably be a nasopharyngeal primary.
Yes. Sir.
What is a host triangle?
Sorry, sir.
Ho H-O-O. So you need to look up that, right? If you're talking about
Yes, sir.
nasopharyngeal primary, that's certain things such as these you need to know. Okay, go ahead.
Okay.
Next, what is your examination finding? So what all
So-
you have done now?
So local examination with the cranial nerve examination followed by diagnostic nasal endoscopy, and I would like to proceed with imaging soon.
You wouldn't want to give a differential at this point? I guess
Yes,
you realize you're presenting a case like how you would present in an exam, and you're not doing a JC presentation. Yeah.
Yes, I would like to present my differential diagnosis after clinical radiological findings. Sir.
So with this examination, you generally don't give a differential diagnosis, is that? Every time you have your biopsy and then your imaging, and then only you tell what your differential diagnosis is.
Sir,
At that time, it probably will be more a definitive diagnosis, isn't it?
Yes, sir. Sir, on diagnostic nasal endoscopy, it most likely appears to be a malignant
Not
lesion.
just on diagnostic nasal endoscopy, it's based
History,
on. So
yes,
at this point, you need to summarize again your entire case, the salient history findings and the salient findings on clinical examination, and then give your differential diagnosis at this point.
Okay. Okay.
I really find it surprising that you're finding it all very new out here. I don't know. Okay, go ahead.
So, yes, sir. So based on my history examination findings and the diagnostic nasal endoscopy, it most likely appears to be a lesion of malignant origin. My differential diagnosis are looking at the area of the nasal cavity involved. It could be a squamous cell carcinoma or an adenocarcinoma or other histologies such as an adenocystic carcinoma. I would like to confirm my diagnosis with a biopsy of the lesion from the most representative area.
So Abhisek, what makes you think it is a malignant tumor only?
Ma'am, the proliferative nature of the tumor and ma'am, yes, ma'am. Mainly, it appears to be a proliferative lesion involving one side of the
Your
nasal
history
cavity.
mentioned that there was an episode of bleeding, right? Does benign tumors
Yes.
bleed except for angiofibroma?
So benign tumors
Which
The-
benign
the-
tumors will bleed?
Apart from angiofibroma, so inverted papillomas can also present with history of epistaxis, sir.
Correct. So inverted papilloma, you will treat it as just a
Not
benign
benign, so
tumor.
locally
You will
aggressive,
treat it
but
aggressive.
more like better said as
Okay.
described as locally
Okay.
aggressive lesions.
Okay. Yes.
Can you think of any other benign or intermediate grade tumors which would bleed other than the ones mentioned so far? Of course, all these are histopathological diagnoses. I mean, at the end of it, but then you need to be aware of those. If you do take a biopsy and it comes out to be whatever, what
Correct.
will you do?
Very, very important. Very important. Yeah, very important.
So what are the other such tumors? So that is what. So when so again, a point here that I want to emphasize here is don't take sinonasal pathology lightly, and don't take that it's just squamous cell carcinoma or olfactory neuroblastoma.
Yes,
There is much more to it, and you need to be really careful and sharp, and guide your examiner towards it, and give a sense of due diligence being done when you're taking this case. You're trying to
Yes.
assess. Essentially need to this.
Hello.
Hello.
I think there's some network issue from Sir's side.
There's a network issue from the side. See, I would like to just tell you one thing. What Sir wants to say is cases, nasal cavity, paranasal sinus case, once it comes in your exam,
Yes, sir.
you have to realize that it is something, if you are prepared very well, that you can actually lead the examiner towards things which you want to answer.
Yes, sir.
It is one of those kind of cases where there is not enough literature, like you don't have any much
Yes.
of trials,
Yes, sir.
much
Yes.
of papers on that. So that is one good thing. So if you are seriously interested, what questions are going to be asked upon your examination, your cranial nerves, your nasal endoscopy, your diagnosis. So Sir asked a very simple question: which tumors bleed? Have you
Yes,
ever
sir.
heard about angiosarcoma, hemangiopericytoma? These are the
Yes, sir.
tumors
Yes,
we have.
sir.
Yeah, simple tumors like hemangioma.
Yes.
Simple things. Okay? These are the questions which have been asked at the time when we were in ENT, basically doing our postgraduate things. So
Yes, sir.
these questions need to be answered. If you falter in these questions in your MCH exam, then there is a big issue.
Yes, sir.
Also, Abhishek,
Sir,
also remember that there are certain metastases from distant sites which can present as nasal mass. So
Okay.
and that can bleed.
Yes, sir.
Yeah, that can bleed profusely.
Right, sir.
Do you know what are those sites?
I was just about to ask the same question. Which sites predominantly metastasize to the paranasal sinuses? This is a very, very, very important question, and very, very favorite questions for examiners.
As in, like, which sides which side metastasis to the nasal cavity?
Yeah, patient will present as nasal epistaxis. Patient will present as nasal epistaxis and nasal mass, nothing else. But on further biopsy and all, it will turn out to be a disease from other primary, very distant primaries.
Yes. I think it's a renal cell carcinoma. I think the metastasis.
Yeah, correct. One is that. Renal cell mets, you may all know that anywhere the mets are quite vascular.
Yes, sir. And
there are 2-3 couple more
yes,
sites.
Renal cell, I think CA breast is also known to spread to the nasal cavity along with intracranial mets. Along with that, I'm not sure, but I think I've read prostate also.
Just there are a couple more. Just read this. Yeah. They're very rare. They're very rare.
Okay. Yes, sir. I'm not able to recollect anymore. I think renal cell, breast, and prostate. I have read, sir. I'm not sure about.
Yeah. Read about it. Read about it.
Yes,
It's an important question.
May I proceed, sir?
Yeah, please go ahead.
Yes, sir. Coming to the imaging, sir, we have done a contrast enhanced MRI of the paranasal sinuses. These two are axial and coronal T1 weighted images with contrast. I would just like to play them, sir. Proceeding from cranial to caudal, here we see the orbit which appears grossly normal. There is an enhancing lesion in the right side nasal cavity, which is expanding the osteometal complex on the right. It is mainly it is mainly situated in the right side ethmoid sinuses, and posterior extent is absent. The nasopharynx looks grossly normal. There seems to be lateral extension into the maxilla through the osteometal complex. The findings are further seen in the coronal cuts as well. The orbit appears to be grossly normal again in the coronal section that is provided. And I would also like to view the T2 weighted images to differentiate the extent of the differentiate tumor and the inspissated secretions to give us a better understanding of the true extent of the disease. So as you can see here, the tumor does not have it. It is extending to the maxilla, but there is not a lot of lateral extension. It is mainly the secretions that are retained in the maxilla, which are seen to light up on T1 weighted images.
Abhishek used proper terminology. They are called hyperintense. Okay,
Yes,
lighting up we
yes,
use in
yes.
PET CT.
Yes, hyperintense. It is a T2 hyperintense on the secretions are T2 hyperintense. Yes, sir.
Any comment upon the plane with the lamina papyracea?
Yes, sir. It seems to be aborted. However, it does not appear to be involved, and the extraocular muscles also seem to be free from the tumor. Grossly, the lamina papyracea does not seem involved. I said so.
Okay. Now I'll ask you a very basic question. Why
Yes,
was MRI done as the first choice? Why was not a CT scan done?
So here the one of our concerns is superior lateral extension, superior extension to the orbit, and orbital involvement is better made out on MRI. So if we were to go for one investigation, it would be MRI. However, both CT and MRI are they go hand in hand. They are one can use.
Okay, so given an option, what all imaging investigations would you do for this patient? First and second. Rapid fire question.
Yes, sir. So given an option, I would like to do both a CT scan and an MRI of the PNS for this patient. CT scan
Okay.
to.
But it's
Yes,
a rapid fire question. Second, what are the points which you would like to see in an MRI of this patient? Name 1, 2, 3, 4, and 5.
Yeah, so the location of the tumor, the extent of the tumor, involvement of the septum medially, involvement of the floor, superior laterally involvement of the lamina papyracea, the extraocular muscles, and subsequently the orbit, and to differentiate the tumor from any secretions. On
Okay.
yes, on
I'll give you
CT
2 more minutes. Anything else? Anything else on MRI?
Involvement of the cribriform plate as well, sir.
Anything else?
So more nodal involvement, I put better seen on CT scan, sir.
Okay, which one?
Any perineural spread is seen well on MRI, sir.
See, when somebody is asking you a question, your answer should be pitch perfect. You can take your time, take about a minute for you to assimilate your answer and speak. Only then you speak.
Okay. Yes, sir.
You have seen your MRI. You know that the MRI, the epicenter of the disease is somewhere around the middle meatus. So probably at the osteomeatic complex region.
Yes, sir.
Okay, so now you need to see where all the disease is extending. So first and foremost, you want to see the extent of the disease into the maxillary sinus. Why? Reason is, if the maxillary sinus is extensively involved, then the treatment would be a maxillectomy, which would be an open procedure. If
Yes,
the
sir.
tumor is just peeping into the maxillary sinus, the treatment will change. You can do an endoscopic medial maxillectomy. Agree?
Yes, sir. Yes, sir.
Secondly, if the tumor is involving the sort of the roof of the maxillary sinus and the ethmoidal complex, then you would like to see what is the relation with the lamina pepraceum, whether it is intact or it is dehiscent. If it is dehiscent, how close are the muscles? Are the muscles involved? Is the fat involved?
Yes. Yes.
Okay. Superiorly, you want to see what is the relation with the cribriform plate. Is there any invasion of the tumor through the cribriform the olfactory fibrils beyond the cribriform plate in the frontal lobe?
Yes, sir.
Getting it?
Yes.
If
Yes,
there is
sir.
any dural involvement, what is the lateral extent? Is the dura just reactively involved, whether it's just inflamed, or is there a specific nodularity in the dura which will tell you that the dura is actually involved? So critical structures, orbit involvement, dura involvement. You forgot. God has given us the opposite nostril. Opposite side mein kuch hai ki nahi? Is there anything in the opposite side?
Yes, sir. The opposite nasal cavity looks grossly normal. Yes, sir.
Agreed. So the last and foremost, most important is, which is the first echelon lymph node for your paranasal sinuses?
The retropharyngeal node, sir.
Would that be seen better in an MR?
No, sir. CT scan, axial contrast and CT scan, axial cuts would better show retropharyngeal node, sir.
Sure.
Yes, sir.
No, or you, sorry, I just had lost the signal in between. So,
Yes, sir.
Abhisek,
Yes,
are
sir.
you sure it's in the CT scan better, or where else? So that means mostly we are comfortable reading the CT scans now. We have never seen the MRI for a retropharyngeal node. That probably might be the truth. But then you can see it pretty much well in the MRI as well.
Okay.
CT, of course, yes, because and also that's a common investigation that you do for the
Modality used, yes.
other sites. And for what Ankit was mentioning here, I'm not sure. I was not there before. Which sequence will you look for all these? Will you just look at any T1, T2 weighted image, or any particular sequence you would look at for any particular thing?
Yes, sir. So to see the extent, the location and extent of the disease, I would like to see a T1 contrast MRI, axial and coronal cuts. And like I mentioned, sir, to differentiate the tumor from the retained secretions, I would like to view T2 weighted images, sir.
And so you will not even do an MRI with contrast at any point?
Yes, axial T1 weighted with contrast, I would like to for tumor localization.
Okay. Ankit, would you agree with what he says? You have anything else to say, Ankit, Kaberi?
You should always mention that it's a T1 with contrast. And please see, not just the axial, you see the coronal, you see the sagittal, all planes give you a 3-dimensional, the planes are required because that will give you a 3-dimensional picture about what the disease, where is the disease extending.
Okay, yes, sir.
A T1 plane is going to give you the knowledge about the anatomy. T1 with contrast, the tumor will enhance. The T2 will give you the exact site of the tumor, the exact location of the tumor will help you differentiate it from the chronic inflammation of chronic rhinosinusitis and thickened secretions. You have diffusion, which will help you in post-op, post-RT cases to see whether there is any sort of residual disease or any recurrences in that region.
Okay, yes, sir.
Abhisek, any role of diffusion-weighted sequences in sinonasal masses? I'm giving a hint of COVID.
To look for invasive fungal, to rule out invasive fungal rhinosinusitis, sir. To differentiate the tumors from
infections and all.
Yes, sir.
Sometimes
since you mentioned fungal sinusitis, what is the characteristic picture of a fungal rhinosinusitis on MR?
So it, unlike a tumor, it will not be enhancing, so it's not a vascular lesion, unlike a tumor. There won't be any enhancement on T1 weighted with contrast.
Okay. And
So
what about the T2?
T2,
Fungal sinusitis. Yeah, bolo.
Yes, so T2 will be hypointensive.
Fungal sinusitis are dark. If you ask any
Yes.
any radiologist, they will tell you a T2 dark in a patient with chronic rhinosinusitis
Yes.
picture
Yes.
goes more in favor of fungal sinusitis.
Yes.
Go ahead.
Yes, sir. So after performing the imaging, we have so a biopsy was done, which showed the tumor to be an adenoid cystic carcinoma. Just to mention, we have also done a non-contrast CT scan of the thorax to rule out distant metastasis. Seeing as the histology is, as this type of histology is known to have distant mets in roughly 18 to 20%. And so the NCT thorax was normal.
Okay, I have two questions. First,
Yes,
let us just finish off with the MRI. Does MRI help you in identifying a disease pathology, a specific pathology in the nasal cavity? A specific pattern of the MRI will help you figure out what that pathology is,
sir,
and a corresponding CT. Yeah, go ahead.
Yes, so in inverted papilloma, the characteristic cerebriform pattern is characteristic of
Very good.
inverted papilloma.
Okay, and what
the
about
loss of
a corresponding CT? You do a CT of the same person. What specific
Yes,
things
sir.
would you identify, and how is it helpful? So if you do a contrast CT of the same patient, you will identify
Yes,
that
sir.
there are areas of calcifications. And
Okay, yes,
that areas of calcification are primarily those areas where the disease is actually starting from. So the epicenter of the disease would be that. And in
yes,
area where in a patient we have extensive inverted papillomas and you want to target a particular area for biopsy, look at the CT, target those areas which show some dystrophic calcifications. Probability is high that you might end up getting a positive squamous diagnosis rather than an inverted papilloma diagnosis.
yes, understood.
Okay.
Yes, sir.
And secondly, you said adenocarcinoma. Was any IHC done on them?
Adenoid cystic.
Adenoid cystic carcinoma.
Yes.
Okay. Any specific details about the adenoid cystic carcinoma, grade 1, 2, 3 on the
So
biopsy?
grade 2
What did
adenoid
tell you?
cystic carcinoma, sir. It showed roughly 60 to 70% solid pattern. And
Okay.
so they've called it grade 2 adenoid cystic carcinoma.
What are the grades of adenoid cystic carcinoma?
So based on the solid and the based on the solid component, the higher the solid component in the tumor, the higher the grade. It's 1, 2, and 3.
Something called a scribriform, tubular, solid.
Yes, the type, the tubular, cribriform, and the solid patterns of adenoid.
So that's what I was asking. I didn't ask the
Okay.
I didn't ask the details of it.
Okay.
Okay. Adenoid cystic carcinoma. Okay, go ahead.
So I would for my management, I would like to counsel the patient that counsel the patient for surgery. I would like to attempt an endonasal endoscopic resection of the tumor and I would also like to counsel the patient for an SOS open approach in case I am not able to access the lateral extent of the tumor.
Hello, Abhisek, can you hear me?
Yes, I can.
Yeah. So what I was trying to ask was, how do you grade the adenoid cystic carcinoma as a grade 1, 2, and 3? How much percentage of solid? You said 60% is solid, right?
Yes, sir.
How much percentage beyond which it's also what is it? It's still they've called it intermediate grade?
Yes, a grade 2 was what was this?
So beyond what grade of solid component do they call it? What?
So less than 10% solid is grade 1, 10 to 30 is grade 2, sir. And anything more than 30 is at grade 3 from whatever.
You're saying intermediate.
Yes, so this it should be grade 3, so high grade.
What are you saying? I mean, you.
No, sir,
that-
it is
that-
grade
what-
3 only. I'm not sure about the the percentage of solid component, but it is anything more than 30% solid component is we would call it grade 3.
Because you've been frequently saying grade 60% consistently. So I presume it will be 60%. So what is
No.
its importance? Does it have any relevance?
So higher grade, I would the mainstay of treatment remains surgery. But I would also opt for adjuvant radiation in a higher grade of adenomyocystic.
And also it will help you prognosticate the patient, counsel the patient, isn't it?
Yes.
So the
yes.
grade is very much important. You cannot
Yes.
just say the grade as casually as this, because in adenomyocystic carcinoma, that is an important part
Yes.
of your decision making. Right. Please continue.
Yes, sir. So, like I was saying, I would like to counsel the patient for surgical resection with an endoscopic endonasal approach, and also like to counsel the patient for an SOS open approach in case I'm not able to access the lateral extent of the tumor.
Okay, Abhishek, what would be your indication for an endoscopic, and when would you not go ahead with an endoscopy?
Yes, ma'am. So, any intranasal tumors which have a lateral extension which may preclude an endoscopic approach, or with tumors extending to the frontal sinus, or with orbital extension. These
Frontal sinus, you won't go ahead with
frontal sinus
endoscopy?
going to the lateral recess, ma'am.
Is there any limit? I mean, when do you say it will not be amenable for
Roughly,
endoscopy?
ma'am,
There are certain points, right?
roughly a plane lateral to the lateral toward the vertical mid-pupillary line is generally considered undissectable via the endoscopic approach.
Okay, and then?
Otherwise, involve the palate involvement, skin involvement, or the lateral zygomatic recess. If these structures are involved, these preclude an endoscopic approach. It would be better to access via an open approach.
Orbit, anterior, bony framework, and all those things?
Yes, ma'am. The anterior wall of the maxilla, the orbital involvement with involvement of the extraocular muscles would also preclude an endoscope.
So there are certain points which say if you find this, you can't go ahead with an endoscopy. So you have to know it properly. Okay, you cannot
Yes, ma'am.
fumble at this point because there are certain very few points. I mean, it's very clear when can you go ahead and when can you not. Okay.
Okay. Yes, ma'am.
Okay, go ahead. So here, what structures are you planning to remove endoscopically?
Ma'am, looking at the MRI, it would most likely entail endoscopic medial maxillectomy, ma'am.
Okay. And what would be the boundaries?
Ma'am, so medially is the nasal septum, the floor of the nasal cavity. Laterally, I would like to excise the.
That would be your lateral margin, or what? That's your lateral limit. You'll
Ma'am, the
take the
lateral,
septum.
the medial limit would be the septum, ma'am.
So you will take the septum, you will not take the septum.
Ma'am, if the disease is free from the septum, then I would like to spare the septum, ma'am. Anteriorly is the lacrimal duct. Posterior is the posterior wall of the maxilla.
Okay, and
laterally is the zygomatic recess, ma'am.
zygomatic recess.
Are you sure that is your
Yes, are you
final?
sure?
think so.
Abhisek, you are from an ENT background?
Yes, sir.
So you know, now you would have done an endoscopic medial maxillectomy, right?
Yes, sir. So the disease seems to be not completely involving the maxilla, sir. So
But
Agreed.
you do you do medial maxillectomy when the maxilla is not totally involved, right? Otherwise, you would have
yes,
removed.
yes.
So when it is in the ethmoids, then the resection is the medial maxillectomy. You have to know the structures which you remove.
Yes, ma'am. The anterior to the lacrimal duct will be my anterior border of resection. The middle turbinate osteometal complex would come in my resection.
Conference.
Hello, Abhishek.
Yes, sir.
If I say in this MRI, the nasolacrimal duct is involved, what does it mean to you?
So I didn't understand. Like as in
So if the
in terms,
nasolacrimal duct is involved,
yes, sir.
will that have any bearing on your kind of
So
approach
then
that you
that would
use?
preclude an endoscopic resection. So we will have to excise the lacrimal sac as well. So that would have to be done via an open approach.
Right. So when that is the point, then you'll have to convert it into an open approach, and it may not be the he might not be a candidate for a endoscopic.
Endoscopic.
Right. Any other question?
Kaberi, did he answer what are the indications for open approach versus endoscopic approach?
He just told when not to do endoscopy. Not separately.
Abhishek,
I mean,
simply put,
contraindications of
3
endoscopy.
points.
Yes, sir.
Simply put, tell me 3 points where will you do an open approach and will never attempt an endoscopic approach.
So orbital involvement.
Agreed.
Externally, the palate involvement, bony involvement of the floor
Bone
of the
involvement, agreed.
and skin of the maxilla, anterior cheek skin.
Okay, so skin involvement, orbit involvement, and bone involvement.
Yes, sir.
Agreed. You were saying something about the frontal sinus. What involvement of the frontal sinus would you consider doing an open approach, and what can you still go ahead and do with an endoscopic approach?
So a draft procedure can be done, sir, but the lateral recess of the frontal sinus, if it is
Draft kya hai? What is the draft procedure?
Tell the types of drafts.
Hello, sorry, sir.
What are the different
please
types
tell me the type of draft procedures.
Different types.
So draft one. I'm not able to recollect, sir.
Can you tell the name of the person, the full name?
No, sir. I don't know the full name.
Wolfgang Draft. He's a German.
Okay.
Right?
Yes.
Yeah, and there are 3 types of draft procedures that he had mentioned. And what are those? What are the differences between the 3 types?
So I know that draft 3 is where the entire bilateral frontal sinus and the posterior part of the nasal septum is excised, and the entire frontal sinus, both the bilateral frontal sinuses are made into one open cavity.
So what is the lateral extent from what to what? Draft has always been defined as widening of the frontal sinus opening or frontal recess from one structure to the other structure. So draft 3 is from one lamina pepratia to the other lamina pepratia.
Yes.
What is Lothrop? Any idea?
So draft 3 is also called the modified Lothrop.
Okay. So my other question was, which bone of the frontal sinus, if involved, will always be an open procedure?
Of the frontal bones, the cribriform blade.
Frontal sinus.
Okay. The posterior table, sir.
Okay. Whenever we are doing an endoscopic craniofacial dissection, what access we get is a good amount of posterior wall of the frontal sinus is
yes,
exposed. So
and
if you have any minor erosions of the posterior table of the frontal sinus, that could be easily drilled off. But any erosion of the anterior wall of the frontal sinus would be very difficult to drill off. So basically, if the anterior wall of the frontal sinus, even if the lower half is gone, the treatment would become, you have to take down the entire anterior wall of the frontal sinus. So that will entail an open procedure.
Okay, understood.
Any pre-op preparations for this fellow?
As in just prior to the surgery, sir? As in immediately.
Is there any way you would like to prepare the nasal cavity for the surgery?
Yes, I would like to pack the nasal cavity with pledgets soaked in nasal decongestant for better visualization of the tumor, sir. Hello?
Yeah.
Yes, sir. So decongestion with
Got it.
Yes.
Sir, Shiva sir, Kaberi, Neelesh, should we go ahead with surgery and post-op adjuvant?
Yeah. Maybe bigger.
Yeah.
Time is almost. Yeah. So please go ahead, Abhisek.
Yes, ma'am. We have ma'am, so the HPR has not come yet, ma'am.
What about the neck? What would you do to the neck? Because there is a palpable nodes, right?
Yes, ma'am. So we had actually done an a USG guided FNAC of the nodes, and those were reactive, ma'am. So
All the three nodes?
Sorry, ma'am.
All the three nodes?
Yes, ma'am. Yes, ma'am. So the FNAC was reactive, so we may avoid a neck dissection.
So then you did the surgery, and after that?
Ma'am, based on the histopathological report, I would counsel the patient. I would counsel the patient whether it is adjuvant RT is required or not.
So you told it was 60% solid component, right?
Ma'am, it was grade 2, ma'am. I think it will be less than 30%. But if there is 60% solid pattern, it will be grade 3, ma'am.
Okay, but when do you give adjuvant radiation irrespective of whatever is the features in the histopath in an adenoid system?
Ma'am, high grade adenoid cystic with PNI and not in this case, but if the patient has cervical metastatic lymphadenopathy, or in case of positive margins.
Okay, so that is a histopath feature. But would you go ahead with radiation, adjuvant radiation in all high-grade adenoid cystic?
Ma'am, generally yes, but
Yes, we do. Huh?
Yes, ma'am.
And in this case, would you ask for a radiation to the neck, even if that is negative, or would you observe the neck from the radiation point of view? Surgery you didn't do, but prophylactic irradiation would you do to the neck, or would you observe?
No, ma'am. If the prophylactic radiation to the neck may be avoided, since it has been histopathologically proven to be negative.
Okay. Shiva sir, Ankit, the organizers have asked to wrap up.
Abhisek, how will you follow up this patient? What intervals you want to see, and what investigation will you do and follow up?
So I would like to follow the patient up 3 monthly with routine diagnostic nasal endoscopy to rule out any local recurrence.
Any imaging?
routinely, I would not recommend an imaging. But if there is high grade, if it is a high grade adenocystic, 6-monthly MRI may be performed along with the CT thorax.
So adenoid cystic, you need to watch out for distant meds, right?
Yes, sir.
Yeah. So when will you do CT thorax?
I think generally, so 6-monthly CT thorax may be advised, sir.
No, but then if there's going to be any lesion in the thorax, are you going to keep doing it every 6 months? So the thing is, from the baseline, and then at least once annually should be good enough.
Okay.
To just see if there are any new lesions that are there, or so the discussion from here on will go into metastatectomy and what is the definition of oligometastasis and things like that.
Okay.
I think it's 7:05 now. I think if all agree, I think we can stop the discussion here and hand it over to Komal.
Yes, sir.
Yes,
Yeah,
sir.
Kaberi. Yeah.
Yes, sir.
Yes, sir. Yes,
Agreed,
sir. Sure.
Right. So actually, the discussion from here will go on into oligometastasis definition and metastasectomy. So
Thank you,
Abhisek, so we'll stop it here. Over to you, Komal.
Sir, Abhisek will kill me, sir, if that discussion goes there.
Sorry.
Sir, nothing, sir. It's just,
No,
sir, carry on, sir.
Yeah. I think we can wind up for now. I think. See, the point here is that I just would like to mention to Abhisek that I think he would agree himself, and this is my comment. I'm not sure with the others, and that he needs to read a lot, and your examination and presentation finding shouldn't be just a casual passing comment. It has to be, it has to be whatever you mention has to be mentioned diligently after due consideration of what you're going to say and what you're not going to say for whatever reason.
Yes.
If this is not followed, then